Hello, I'm Peter Libby from Boston's Brigham and Women's Hospital and the Harvard Medical School. It's my pleasure to participate in this virtual edition from Canada of the Cardiology, Diabetes, and Nephrology at the Limits. I certainly hope that next time we'll be able to meet in person. I was assigned the topic of coronary atheroma at the limits. Are we fighting the final battle? These are my financial disclosures. Suffice it to say that I decline all personal compensation from pharma or device companies, but I do a lot of consulting. Well, I'm going to give you the bottom line right up front, is we've made great and gratifying inroads into cardiovascular risk management, but by no means have we reached the limits. And I'm going to illustrate that in this talk. Let's start with some real-world data from a first-world country, Sweden, where they have a national database where they have outstanding intervention, cardiovascular care, and pharmacologic treatment. This is the cradle of the statin trials. And what you can see is if you look at a selected group of people who survived a myocardial infarction who are young and have low risk, that they do rather well. Less than 10% recurrent events in the first year following the index myocardial infarction. But these patients in my practice are few and far between. The kind of patients that I saw in clinic this week and that I'll be taking care of in the inpatient service all of next week are more like these patients up here, the elderly and with comorbidities such as diabetes or impaired renal function. And if we look at these patients, which really reflect my practice and perhaps your practice, we see that the recurrent event rates, despite outstanding intervention and pharmacologic therapy and a really excellent healthcare system, unacceptably high residual risk. About a third of the elderly high-risk patients will have a recurrent event in the first year following myocardial infarction. So just from the starting gate, we can see we have a job that is unfinished. Now, one of the great victories of cardiovascular science and medicine in the last century was the fantastic body of work that demonstrated the causality of low-density lipoprotein, LDL, in atherosclerosis and atherosclerotic events. LDL satisfies modified Koch's postulates. There is a consistent and plethora of epidemiologic observational studies that show an association between high LDL and high cardiovascular risk. There is a fantastic database of genetic studies ranging from monogenic disorders to polygenic risk scores that provide very strong human genetic evidence for the causality of LDL in atherosclerosis and atherosclerotic events. And then, and very clinically relevant, there are the intervention trials that have shown that if we address LDL with pharmacologic agents or otherwise, that we're able to reduce cardiovascular events. So this is a very nice, satisfying package that shows that LDL indeed is a causal risk factor. Now, how do we go about attacking cardiovascular risk? Well, I just use this slide to make the point that lifestyle remains the foundation of both primary or primary, and secondary prevention. You'll hear a lot more about that from John Deanfield. But we're fortunate that in addition to lifestyle, we have a full palette of pharmacologic approaches to managing LDL. We have the statins, we have the cholesterol absorption inhibitor, ezetimibe, we have a new agent, bempedoic acid, that acts a step or two higher in the cholesterol biosynthetic pathway from statins. And then we have this wonderful story of the anti-PCSK9 agents. We have in hand today the antibodies, and we have on the horizon, and very exciting, the RNA therapeutics, which can be given only once or twice a year and make substantial reductions in LDL. So we actually are approaching the limits with LDL. These are data from my colleague, Robert Giuliano, from the Fourier study that show that if we look post hoc at the different strata of LDL lowering in trial, down to 20 milligrams per deciliter, that we have progressive benefit in terms of reduction in events. So we're able to plumb the depths of LDL and reap the clinical benefits. And I have one patient whose LDL is 6, and the patient is happy, and I'm happy. And the patient can actually remember where he left his car and find his keys. But there's more to the lipid profile than LDL. There are also triglycerides. Triglycerides are a mere biomarker for a class of particles that we can call triglyceride-rich lipoproteins, or TGRL or TRL, or they also can be referred to as remnant particles. And maybe it's not the triglycerides themselves that are packaged in these particles that are pathological, but it is the cholesterol that they ferry and are able to enter cells more readily than LDL, which of course is exquisitely regulated. The HDL story is one that we've learned a lot about in the last few years. The HDL cholesterol in a population indubitably correlates inversely with cardiovascular risk. But that very strong association doesn't mean that HDL cholesterol is a causal risk factor, or that if we augment HDL levels pharmacologically or otherwise, that we will reduce clinical events. And summing up a great deal of data, pharmacologic attempts to raise HDL cholesterol have failed consistently to reduce cardiovascular events. The human genetics that we have in hand today provide weak support, if any, for HDL-C as a protective cardiovascular risk factor. That is, variants which lead you to have a lifelong increase in HDL do not correlate with the outcomes, which is contrary to the case that we mentioned with LDL. In contrast, studies over the last half dozen years or so from human genetics strongly support triglyceride-rich lipoproteins as a causal cardiovascular risk factor. I wrote up actually quite a few years ago now a rather provocative piece called Triglycerides on the Rise. Should we swap seats on the seesaw? And of course, the seesaw that I was referring to was the inverse relationship between triglycerides and HDL cholesterol. For generations, we adjusted triglycerides for HDL. So fervent was our belief that HDL was protective, and that would attenuate the risk associated with the triglycerides or triglyceride-rich lipoproteins themselves. But indeed, we may have confused the dependent and independent variable when we adjusted the cardiovascular risk of triglycerides for HDL. And we now have this very strong human genetic evidence that it is variants that can alter triglyceride-rich lipoprotein levels that actually are causal in atherosclerosis. What are the mechanisms by which these particles can provoke atherosclerosis and its events? They are varied, and the scientific basis is less well established than for LDL. But if you wish to read about it, this is a piece which we wrote up recently that goes into some of the mechanisms by which triglyceride can be, or triglyceride-rich lipoproteins can be atherogenic and precipitate events. Now, to make this clinically actionable, there's a great deal of excitement that one of the many large-scale clinical trials of fish oils actually showed a benefit. And that was, of course, the REDUCE-IT trial with highly purified pharmaceutical grade and quality controlled icosapentaenoic acid, known as icosapent ethyl. And although the title had hypertriglyceridemia in it, actually, if you look closely at the data, that's only part of the story. By the way, since At the Limits is based in UK, I can't resist hearkening back to Hugh Sinclair, who was the advocate for fish oils and engaged in some auto-experimentation in the last century that suggested there might be an antithrombotic effect of fish oils. So if you delve into the data and reduce it, and you divide the population into those with different tertiles of baseline triglycerides, you see that there was no heterogeneity. The benefit was the same if you entered with lower levels of triglycerides or higher levels. So triglyceride lowering may contribute some to the benefit that was seen in REDUCE IT, but certainly does not explain all of the benefit. What have we got in the pipeline in order to manage hypertriglyceridemia? There is a study known as Prominent, which is a large-scale cardiovascular outcomes trial that I'm involved with. It's being led by my colleagues Aruna Pradhan and Paul Ritker. And we are using a novel selective bPAR alpha modulator known as pemafibrate. And the study is fully enrolled, and we expect to have an answer for you in a number of years about whether attacking triglycerides in a selected population that has hypertriglyceridemia, as you see here, the entry criteria are requiring triglycerides from 200 to 499 in millimoles next to it here. We're going to, for the first time in a fibrate trial, actually enroll people with hypertriglyceridemia and see if we can make a difference in cardiovascular outcomes. Now, beyond LDL, HDL, and triglycerides, we have a number of novel targets, and a number of these actually have been validated by strong human genetic studies. There's that vexing final frontier of lipidology, lipoprotein a, which we've known is associated with accelerated atherosclerosis and events for decades. And now we have very good genetic evidence that it is causal. And we have a very exciting prospect of at least 2 RNA therapeutics that are targeted for the hepatocyte that can lower Lp(a), one of which is already in a large-scale phase 3 outcome trial. We have approaches to treating the other aspects of lipid regulatory proteins, such as angiopoietin-like protein 3 or apolipoprotein C3, a modulator of lipoprotein lipase. These agents are in investigation. Phase 2 data have been published and are very promising. So we can look forward to expanding the bandwidth of our ability to address abnormalities in the lipid profile. But there's a lot more left to do in terms of controlling cardiovascular risk. There are targets beyond lipids. There's inflammation, there are somatic mutations, and then largely red insulin resistance, which will be a topic of other talks in this series. So let's start for a moment with inflammation. If you go on Google Scholar and cross inflammation with atherosclerosis, it takes you a matter of nanoseconds to find over 1.5 million hits. And there's a huge literature, preclinical literature and biomarker literature suggesting that inflammation contributes to atherosclerosis and the mechanisms of generation of events. But the challenge is to cross that valley of death of translation, to go from our laboratory into our patients and see if a targeted anti-inflammatory therapy can actually improve cardiovascular outcomes in people. The first shot on goal was targeting interleukin-1 beta, a pro-inflammatory cytokine. I've been working on interleukin-1 for a number of decades. And if you would like to learn about the scientific basis of this trial known as CANTOS, the canakinumab anti-inflammatory thrombosis outcomes study, I refer you to this fairly recent review in the Journal of the American College of Cardiology. Everyone is, I think, aware of the top-line results of CANTOS, which targeted interleukin-1 beta with a monoclonal antibody. This is an on-treatment analysis looking at the individuals who achieved a substantial anti-inflammatory effect by lowering in the biomarker of inflammation, C-reactive protein, measured with a highly sensitive assay, that's HSCRP, who achieved greater than median reduction. And as you can see in the blue bars, that there was looking at cardiovascular mortality or all-cause mortality, a significant decrease of over 30% including all-cause mortality, which is the holy grail of all cardiovascular outcome trials. Of course, this was an on-treatment analysis that's subject to confounding. And if you peruse this Lancet paper, you will see that the study statistician, Bob Glynn, did something like 7 sensitivity analyses to try and control for confounding and was unable to obliterate the striking benefit for those who responded to the drug by lowering their CRP. Well, will all anti-inflammatory agents yield clinical benefit as neutralizing IL-1 beta did in CANTOS? Second trial that was the brainchild of Paul Ridker and led by Paul used low-dose weekly methotrexate, which is a therapy that has transformed rheumatology and particularly the treatment of rheumatoid arthritis. And all of the observational data from the rheumatologic and dermatologic studies suggested that this regimen should lower cardiovascular events. Yet, in the impeccably conducted large-scale randomized clinical outcome trial, as you can see here, whether you look at major adverse cardiovascular events or MACE plus, including revascularizations, there was absolutely no effect. But in the population studied in SIRD, there was not an anti-inflammatory effect. There were no significant reductions in these indices of inflammation and no change in LDL-C. So although this is a anti-inflammatory therapy that has proven very useful in rheumatologic diseases, it did not provide a benefit under the conditions studied in the cardiovascular inflammation reduction trial. So it's quite in contrast from CANTOS, where the biomarkers of inflammation went down and there was a reduction in events, but there was no change in these biomarkers of inflammation in the cardiovascular inflammation reduction trial and no reduction in the endpoint. Now, the palette of anti-inflammatory therapies has expanded. We've become familiar with the use of colchicine in cardiology over the last decade or dozen years because of its efficacy in treating pericardial disease. But the LODOCO study, which was a pilot study, not a blinded study, suggested a remarkable benefit in secondary prevention. And the first of the 2 large-scale clinical trials that were blinded and placebo-controlled, COLCOT, showed this striking decrease in events in patients who were treated with low-dose colchicine, 0.5 milligrams daily. I want to point out, since this is a Canadian-based meeting, that this study was led by Jean-Claude Tardif in Montreal and was supported in large part by Canadian resources and Canadian brain power and person power. A second study was conducted by the individuals who were engaged in the first pilot study, LODOCO, called LODOCO-2. It reported last year and really confirmed the results in a stable population of patients with coronary artery disease. So where do we stand today? In COLCOT, targeted colchicine therapy to people who were in the first 30 days after an acute coronary syndrome. LODOCO-2 looked at people who had sustained a myocardial infarction or acute coronary syndrome, but were in the stable phase. There was one smaller study from Australia that looked at early intervention in ACS, and there was no indication of benefit, and there was even a bit of a concerning mortality signal that might be the play of chance in a small study. So this is a scorecard that I put together with Brendan Everett a year or 2 ago of the different anti-inflammatory therapies that have undergone evaluation in reasonably sized and reasonably rigorous clinical trials. And as you can see, everything works in the laboratory. The pilot clinical studies inevitably show promise if you get to the phase 3 study, but we've had a number of failures in crossing that chasm of clinical translation. And we've been fortunate to have IL-1 beta, colchicine, and omega-3 fatty acids give us positive trials just in the last few years. And of course, there's more to the mechanism of benefit of the omega-3 fatty acids and an anti-inflammatory effect, just as we discussed for the triglyceride lowering effect. So where do we go in the future? There are many cytokines. We started with interleukin-1, but the interleukins go up way into the double digits. And this fairly recent review that was put together by Hafid Etufella and Anant Egri and myself looked in a critical way at the literature supporting interleukin-1 beta, but also the other interleukins and cytokines and chemokines as targets for therapy, the pros and cons. So stay tuned. By the way, this is a stained glass piece which I commissioned of the ribbon structure of interleukin-1 beta. So where do we think the priorities lie in terms of targeting these many cytokines? Well, the pathway which interleukin-1 beta is situated in goes from the inflammasome, which is a sensor of danger and transduces a number of signals from atheroma-related type inputs. This inflammasome can activate the precursors, the inactive precursors of interleukin-18 and interleukin-1 beta. So we were successful here. There are a number of programs in pharma and biotech that are targeting the inflammasome itself, very proximal in this pathway. Then there are the anti-IL-1 strategies, anti-IL-1 alpha and beta, and the receptor. There's IL-6, which is downstream, and recognize that there's amplification loop here. So a little bit of interleukin-1 will beget lots of interleukin-6. And this is an attractive target that attacks the pathway where we've seen success. Certainly one of the potential mechanisms of benefit of colchicine is blocking the assembly of this multi-molecular structure of the inflammasome, because it is a blocker of microtubules, which are required for the intracellular assembly of this structure. So colchicine may have an effect up here. Canakinumab, the anti-IL-1 beta antibody, works here. We should look here at interleukin-6 because we might be able to provide clinical benefit with less impairment of host defenses by going more distal in this pathway. And we have strong human genetic data that support IL-6, interleukin-6, as causal in human atherosclerotic events. There are various approaches to blocking interleukin-6, which has a complex signaling story that I'm not going to go into here, but suffice it to say that we are excited that there is an anti-IL-6 antibody that has entered clinical development. The rescue study was a phase 2 study that is currently embargoed, but that will be presented at the American College of Cardiology meeting, which will be held virtually in May of 2021. And stay tuned for the results of that phase 2. And I can tell you that a phase 3 trial is in the offing to actually begin to fill out the inhibition of this pathway. Well, to wrap up, one can ask oneself, well, what is it that turns on inflammation? And it turns out that LDL itself is not very pro-inflammatory. And when you compare LDL to triglyceride-rich lipoproteins, triglyceride-rich lipoproteins are much more pro-inflammatory than LDL. We know that visceral adipose tissue is teeming with inflammatory cells and pours out pro-inflammatory mediators that can elicit echoes in the artery wall that can promote atherogenesis and events. We're learning a great deal about the microbiome and the metabolites in the microbiome that might accentuate atherogenesis. And then there's something that we call clonal hematopoiesis. That sounds like we've entered the world of hematology oncology, but indeed, somatic mutations that give rise to clones of leukocytes that have a proliferative or survival advantage can associate not just with leukemia, but also with cardiovascular events. And if you'd like to read about that, here's a review that we put together as a team of hematologists, oncologists, and cardiovascular specialists. clonal hematopoiesis, crossroads of aging, cardiovascular disease, and cancer. And the idea is that somatic mutations in bone marrow stem cells can give rise to these clones in just a handful of known leukemia driver genes that can cause a clonal proliferation of cells that we can find in peripheral blood. And while, yes, that's on the pathway to acute leukemia, most people with clonal hematopoiesis will never know they have it and will not develop leukemia, but they have a markedly increased risk of developing cardiovascular events. This is just showing the prevalence of these mutations, just a very small handful. As a matter of fact, two of the genes, DMT3A and TET2, account for the vast majority of individuals who have clonal hematopoiesis, known as clonal hematopoiesis of indeterminate potential, because much like monoclonal gammopathy of unknown significance, most people will not develop a hematologic malignancy. And the striking point about this is that there's a very strong age dependence of having one of these clones, with an inflection point just where cardiovascular disease begins to take off in our population. And if we fully adjust for all traditional risk factors, we see that age is by far and away the most potent risk factor for atherosclerosis. Diabetes more than doubles your risk, but having one of these clones is not far behind diabetes and actually ahead of some of our traditional risk factors, such as hypertension or high cholesterol levels. So clonal hematopoiesis is a newly recognized, potent, and common age-related cardiovascular risk factor. And of course, that opens up doors to incredible new science and potentials for intervention, particularly in our elderly population, and also opens the door to something where cardiology has lagged. You know, in oncology, there are genetically directed therapies routine in practice, but in cardiology, we have absolutely no therapies that are dictated by acquired mutations. And this discovery of the relationship between clonal hematopoiesis and cardiovascular risk opens up the door towards our being able to join the club of precision medicine by genotyping and allocating therapy depending on a particular genotype. And of course, insulin resistance is a topic of many other talks and interest in this symposium. And you will hear about the glucagon-like peptide 1 receptor agonists and the SGLT2 inhibitors and their cardiovascular benefits. And certainly in the case of the GLP-1 receptor agonists, we have hints that they may be anti-inflammatory and may modify atherosclerosis per se. So we're nowhere near the limits. We also, beyond the science, have some important societal and professional issues to address. We need to encourage people to adopt the proven therapies, including healthy lifestyles. You'll hear more about that from other speakers, including John Deanfield. And then very importantly, we need to provide equitable access and implementation of these proven therapies so that all segments of our population in all countries can benefit from these scientific advances. So where are we? Nowhere near the limits in combating atheroma. As Sir Winston Churchill said at a turning point in the Second War, now this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. And I choose to close my talk in this Canadian-based edition of Cardiology, Diabetes, Nephrology at the Limits with the famous Joseph Karsh portrait of Sir Winston Churchill. Why? Because it was actually taken in December of 1941 in Ottawa, the capital of Canada. And the anecdote about how Karsh was able to get Churchill to scowl like that will remain for the question and discussion period. Thank you so much for your attention. This tale of trying to address residual risk could not be complete without acknowledging the hardworking and incredibly gifted and intelligent coworkers that I've had the privilege to work with through the years, and the funding agencies that have supported our work. Thank you very much.